So thanks everybody for hanging out for this Saturday afternoon session. I think this is a great topic and something I wish that I had had when I was building my Reflux Center. I'm Emily Speer, a foregut center surgeon in Denver, Colorado, and thanks to SAGES and the panel for allowing me to give this presentation. So I have no disclosures, including with any of the manufacturers or technologies I'll be discussing today. The main talking points we'll touch on are the goals of testing, how to choose your tools, the big three essential tools for workup, other common tools for workup, more novel tools, and surgical and treatment tools. And along the way, with some of these tools that we'll be discussing, I'll chat about my motivation for offering the services, challenges I've faced with offering them, and lessons learned along the way so that hopefully you can learn from my mistakes. So the goals of testing are to determine the patient's individual GERD phenotype, rule out alternative diagnoses, and monitor treatment response. So how to choose the diagnostic and treatment tools in your toolbox. First, you do not need to offer every single workup and treatment option when you're first starting. Just start with the basics and add specialized services gradually based on patient needs and evolution of your center. And then the rest, I think, is really fun. Just do what you love. So probably most of us in this room do foregut and. So foregut and something else like flex endo, bari, ab wall, general surgery. For me, I loved foregut and surge endo and bari, so I focused on those and kind of let the other things fall by the wayside a little bit. And then finally, decide how you'll measure success. Is it volume and creating a well-oiled machine, offering excellent foregut surgery to as many patients as possible, or is it doing the most complex patients and redos? And if it's the latter, you'll probably want to consider adding more advanced tools early on. And so just like Dr. Choi said, it's a recommendation of multiple societies that pH, manometry, and EGD should be performed on all patients undergoing workup for anti-reflux surgery with a few exceptions. So I want to start with those tests. So first is pH testing, which is part of the big three. You need to have this capability in your reflux center, and the testing should generally be done off antacids. The two most common pH tests are pH impedance and wireless Bravo. So pH impedance measures acid and non-acid reflux, as well as proximal and distal reflux. So if you have a lot of patients in your population that have extraesophageal symptoms, this might be a good test to offer. Bravo avoids a catheter hanging out of the nose, so it's well tolerated. It measures up to 96 hours of data, but it only measures acid reflux so far. So my motivation for offering this service was that it's a basic test needed for patient throughput. And when I started, the GI physicians at my institution were interested in doing the test, but the only issue was that their timeline was around 3 to 4 months, which led to a lot of patient dropouts. So challenges I faced when I started my own pH testing was matching the equipment needs with the demand. Also, you'll have to have a system to ensure you have enough recorder boxes, capsules, pH probes, all those things on hand. You need to have a system for pulling probes, uploading data, EMR integration, billing, making sure recorder boxes are returned. And one thing I've noticed is that patients who get pH impedance testing will always return their recorder boxes because they want their probe removed from their nose, but there can be a lot of shenanigans getting Bravo boxes back. And it's also important to create patient education resources to help ensure patients hold their antacids prior to these tests. Lessons learned were asking for this service up front and owning it. Discuss with your GI partners why you're doing it, and it's for the preoperative workup of your surgical patients. And odds are they'll probably even send patients your way for testing. So the second of the big three is manometry. There have been multiple guidelines and societies and consensus statements stating that preoperative manometry should be mandatory prior to anti-reflux surgery, but again, with a few exceptions. So my motivation for offering this service, in many areas, these are really hard studies to get in a timely manner, and that was the case where I was, but they are very necessary for patient throughput. You can localize the LES for pH impedance probe placement, assess esophageal physiology, exclude conditions that can mimic GERD, like achalasia and aperistalsis. And the challenges that I faced were a lot, probably the most out of any of the tests that I offered. So first, training. A lot of us learned the basics in our fellowships or training, but actually placing the probes, navigating the software, analyzing the data, you need to know all of those details because now you're the expert. But you can take courses through Medtronic, Diversitech, Labori, depending on which system you buy. And then in clinic, you'll need protocols for catheter cleaning and the chemicals used, along with thoughtful patient scheduling to allow for manoprobe cleaning time. And then also training a nurse to place probes and analyze the data is way more labor intensive than I had anticipated. Lessons learned, ask for the equipment and the mano nurse up front. Get at least 2 probes, because if you have one, it will inevitably break and then your program will come to a screeching halt. And then budget for a new catheter every year and then keep the old ones too. Also set a reasonable testing turnaround goal. Our goal is 3 to 4 weeks, but just kind of circle back and see how you're doing on that every once in a while. And the final of the big 3 is endoscopy. It rules out malignancy, helps operative planning, and allows for Bravo implantation. So you'll want to choose a GI block that coordinates with Bravo box drop-offs about 4 days later, depending on how long your study is. Next, having access to good upper GIs, including a protocolized food video esophagram, provides some insight into motility for patients intolerant to manometry. And you'll want to work closely with your fluorotechs, since they're the ones that make these things happen, and honestly, they do most of the reads too. Another important tool is access to a good 4-hour gastric emptying study, since gastroparesis is a solid mimicker of GERD. And then more novel tools include the smart pill, EndoFlip to measure motility. To look for Barrett's, you can use confocal laser endomicroscopy, Watts 3D, swallowable devices. You can use mucosal integrity to look for GERD. These are kind of newish things. And then there are multiple surgical and endosurgical treatment options that you'll want to consider offering your patients, ranging from basic to more advanced. The most obvious ones are hiatal hernia repair, a high-quality fundoplication, and choles. And there are great resources like this SAGES Video Atlas, this is where the video is from, and that helps ensure you're operating within the usual standards. My motivation for offering these services was that just doing the basics really well with minimal complications is a great way to build a name. The challenges that I faced were things were clunky in the OR when I started, supplies were missing, preference cards mysteriously changed. But the lessons that I learned were having a dedicated team and being consistent so that everyone knows what to expect is really important. After the basics, you may want to consider offering feeding tubes, reoperative expertise, because it helps to establish you as an expert when you can help with prior reflux failures, endoscopic anti-reflux surgery, endoscopic complication management techniques, endoscopic ablation and resection techniques, and esophagogastric cancer treatments. And then magnetic sphincter augmentation, or LINX, is another fairly basic, easy treatment option that's great for generating referrals. And my motivation for offering this service was that I had a lot of requests for it and the data were good. The challenges that I faced were prior auth challenges, coding and billing, and then the upfront cost of acquiring 2 of each size of device, which is about $5,500 a device. And the lessons I learned were that for about every 3 LINX referrals I get, probably only 1 is actually a candidate for LINX, but then the other 2 decide upon fundo usually. So it brings in a lot of business, especially with self-referrals and from GIs who were previously burned by fundos before you came. And then also having an upfront conversation to discuss billing standards with coders, billers, and financial and compliance officers is important. Next, POEM procedures like Z-POEM, POEM, G-POEM. These, again, require upfront conversations with your hospital coders and billers. And my motivation for offering these services was that I enjoyed doing them, they're minimally invasive. The challenges that I faced were getting a POEM cart. And again, this is something that I should have asked for up front, because it took me a while to recover patients and referring providers that I lost while I was waiting for the equipment to arrive. Lessons learned, have a dedicated team, and if it's been a while or you didn't learn in fellowship, there are POEM courses like the course at the Oregon Clinic that's been around forever where you can go and learn and relearn. This is one of their videos. And I think one of the most important but sometimes overlooked surgical interventions to consider offering your patients in a foregut center is a bariatric surgery program. And the motivation for offering this service is that obesity and GERD go hand in hand, and treating both, including conversions to bypass for failed fundoplications, requires comprehensive care and support. And the challenges faced and lessons learned were to check bari benefits up front, even on your reflux patients, so you can have a fruitful conversation without a lot of circular what-if conversations, because if they don't have bariatric coverage, it is nearly impossible to get bypass approved. But if you have any tips, please let me know. Keep the entire bari process under one roof, if at all possible, to minimize dropouts. And even though they may be in the same building or office, keep the names of your bari and reflux centers separate, because as it turns out, it can really offend some reflux patients to be referred to a bariatric center. And then finally, align yourself with partners who support your mission and don't consider creating a reflux center your side job. Many hospital administrators don't know what foregut surgeons are and what we do, so just educate them. And then ultimately, if you can't align your basic goals, just know when it's time to make a change. Thank you.